So, hello friends, welcome to the Introduction to Domains session by the Part 3 Summit. And we, the mentors, Dr. Meera Kumar and Dr. Sumi Padarthi, we will be taking forward this group and these sessions. And welcome Dr. Soumya and welcome Dr. Nancy. Can we have an acknowledgement from the participants? Hello, you can also message. Okay, so I think we can continue with the session. And the important domains of this Part 3 MRCOG are 5 domains, that is information gathering, communication, patient safety, and applied clinical knowledge. This communication comes it has subheadings such as communication with patients, relatives, and communication with colleagues as well. So in our further sessions, we will be discussing about each of the domains, particularly each of the domains. And then further, we'll be going with the module-wise sessions, and we'll be discussing the most recent recalls. And so our today's session, it is on information gathering. And how this information gathering is different in MRCOG Part 3 compared to our traditional information gathering. So let's look at it one by one. So here you can see this is a pictorial representation of how much we need to change. How much we need to do the amount of smart work that needs in order to put us into the passing category of MRCOG Part 3 exam. So this here we can see this is our, sorry. So based upon our training, we have always been within our comfort zone, taking traditional history taking, but we make sure that we take all the history. But what Part 3 says is that we need to take only the relevant history, and that requires a lot of training and a lot of experience as well. And we are here to help you with this. So from the comfort zone, we need to go into the other zone where the magic happens, and we enter into the passing category of this exam. So what is this traditional history taking? And what needs for this exam is focused history taking. And so we'll be looking into that now. So traditional history taking, we have always been taught about this from our MBBS, PG, and after that, wherever we use the same format, that is the chief complaints, and we go to history of presenting illness, and then we take the obstetric, gynec history. Even gynec history, we do not generally take the smear or STI history, but this is important when it comes to Part 3 exam. And even obstetrics, we generally miss the complications history and whether the patient has any reproductive plans, all that. Then others are the routine medical, surgical, family history. Sometimes we even miss the allergy or drugs history. That becomes a very important part in this Part 3 exam. And the remaining smoking, alcohol, recreational drugs. And again, examination and investigations is done only if it is required, only when it is relevant. So how are we going to change from this traditional to the focused history taking? Here we can see that the standard care model that we have always been trained is it is driven by the providers. It is focused on diagnosing and only treating the illness. But here, when it comes to patient-centered care, if you had gone through the introduction session, then we would have discussed in detail about what is disease-centered and what is a patient-centered care. So here I'm going to tell you about this again. That is, it is more individualized and patient-driven, and we consider both the emotional and the social factors along with the medical needs. So this is both disease-driven and patient-centered. So how are we going to take this focused history? So focused history, we have to always take history related to both the disease and the patient as well. That is the patient's emotions and the social-cultural factors. So these are the most important factors that we need to concentrate when it comes to patient-centered care. That is the culture, the cultural aspects of the patient, giving care to the patient, showing empathy and sensitively discussing with the patient. That is communication and collaboration. That is, we need to do a teamwork. It's not just one doctor. It is a multidisciplinary care. So we need to step into the disease-centered plus the patient-centered care. How is this done? So once the patient comes to you, first we'll have to confirm the identity and then go into the ICE, which is called the ideas, concerns, and expectations. That we'll be discussing about how this will be taken in the next slide. Then following that, then we need to go into the disease history. Okay, so before that, we'll have to set the agenda and discuss with the patient what she's expecting. All that comes under ICE. Next, we'll start with the symptoms. That is what the patient has come with, either the symptoms or the reports or whatever it is. We will be starting with that. Whatever is concerning for the patient will be started. So in that way, we'll be doing whatever are the symptoms, related systems history, all that has to be taken. Then after that, we usually go into the medical, surgical, family, all that history. But before that, we need to do patient-centered care. That is a social and emotional history. That is how, if it is a disabling condition such as heavy bleeding, pain, then we need to ask her about the impact on the quality of life. How is her mental health? Is she anxious? Is she depressed? And then we need to ask about the support at home, whether her husband or someone at home is there to support her. And if relevant, we need to ask for domestic violence screening. It depends upon how the patient is communicating and how is the support at home, all that. And then the routine history, that is medical, surgical, family, allergies, drugs, smoking, alcohol, drugs, and BBB is BMI, blood group, and reservations for blood transfusion. So if you can, if you can remember all this small, the short forms, so we can make sure that we do not miss anything. But at the same time, we should not ask any history that is not relevant. In that way, we can score more marks. We will not get any negative marks, but we can score a better marks. And following that, relevant examination and investigations as required. So what is this? Ideas, concerns, and expectations. So ideas is what, suppose a patient has come with pain, okay, or she's having an ovarian cyst. So we need to ask her what she thinks about this. So what she thinks, why is this symptoms are happening? For example, the patient thinks the cyst is a cancer, but it's just a routine cyst or a functional cyst, but she's thinking it's cancer. If we did not take the history relating to her ideas or concerns, then we may not even address her concern that whether this is cancer or not. At the same time, we can immediately reassure her that the chance of this being a cancer is very less. However, we'll be discussing this in detail later. In that way, you will score more marks related in both information gathering and communication with the patient. And next comes the concerns. We need to ask her what are her concerns and what are her expectations. That is, what is the most important thing that she's worried about. And the next is the expectations. What is she expecting out of this consultation? Like, what is there any treatment that she's expecting? If she has come with menopausal symptoms, the patient may be expecting a herbal treatment. She does not want any medications. So if we ask her in the beginning itself, then we may not waste time discussing about all the medications. We can directly go into the herbal history to talk about its pros and cons, and then at the end, secondly, we can talk about the medications. So in that way, we need to modify our communication and history taking according to the patient's wishes and her concerns. So these are some of the few symptoms, that is most common symptoms which a patient comes with. We always need to have a set of questions that we'll be asking if the patient comes with these symptoms. If it is pain, then where is the pain? Is it localized or it is generalized, dull aching, or cramping pain or aggravating, relieving factors? Have some few questions that you can ask one by one. Then if it's bleeding, then how much amount of bleeding, whether there's any clots associated, and since when she's been bleeding. And we can also ask about postcoital bleeding, intermenstrual bleeding. All these are important. In that way, for each of the history, we can have a set of questions, and this we'll be discussing in more detail in further sessions. So yeah, so we have completed the general history taking part, what we need to ask, and how to go about it. And now we come to the individual modules. We have a total of 14 modules. We'll be having 14 stations, and each task is different. So in each task, our approach to information gathering should also be different. So how is it different in each of the modules? So we'll be discussing about that one by one. So first is the teaching and the clinical governance. So most of the time, it would be, if it's a clinical governance, it would be a structured discussion, or if it is a teaching session, then we'll be having a junior trainee or someone who wants to learn something. So in such cases, we need to establish the rapport, like first, I introduce self and confirm identity, and then establish rapport with her, and we need to rule out bullying, also, we need to ask for the reason why she wants to know about this topic. If she comes for, I need to learn about preeclampsia. Why do you want to learn about it? Did you have any past experiences treating a patient? What was the difficulties? And what she already knows about this condition. And if it is like any patient-related kind of things that she wants to learn, then we need to ask about the relevant patient info. That is, what was the age and what was the complaints? A short history. In that way, we can get more points in information gathering. And there is also something called the two-way feedback. You need to get feedback from both the candidate and yourself as well. So all this comes under information gathering in a teaching session. Next, we go to the core surgical skills. Here in core surgical skills, again, it would be anything like steps of a surgery or any steps of a procedure, and these would be the most common kind of tasks in core surgical skills. So again, here we should always talk about the if the patient is has been posted for TAH or BSO, they ask for steps of surgery, but they'll ask what are the more information that you need. Then we need to ask about the relevant patient info. Is there any risk factors and any medical surgical comorbidities, the BMI and blood group reservations, the consent and allergies. These are all important histories that need to be taken in a core surgical skills task. The next, we go to the post-op care. Here, post-op care, most of the times it would be some complication after a surgery or any procedure. So in such cases, it would always be important. Either it would be a structured discussion or a simulated patient task. In both the cases, we need to talk about relevant patient info, the history, how this happened, what led to this, what was the post-op recovery, then the surgery details, and also if you go to the patient and if the patient has already been admitted, it's important to confirm the identity, but you should not ask like, may I confirm your name? You should ask like, am I speaking to? In that way, you can make sure that you're confirming the identity, and at the same time, you make sure that the examiner feels that you're not talking to the patient for the first time. And again, the same risk factors, BMI, blood group reservations, allergies, and post-op recovery. And we should ask the patient whether we can take the consent to access her notes in order to give her better treatment. So these are important histories need to be taken in a post-op care task. Next comes the antenatal care. Antenatal care, we would have done a lot of tasks. Most of them would not be having any doubts related to that. So when it comes to antenatal care, we always take the ideas, concerns, expectations, set an agenda, and then start with the pregnancy details. You can just ask, how was your pregnancy so far? The patient will tell everything. If she does not tell, if it is relevant, you can ask about scan or blood test. If it is early pregnancy, you can ask if it is planned. But if she says it is unplanned, ask for contraception history. If there is a history that contraception is ineffective, then discuss about effective contraception. Just one line. This will give you more marks. Next, if the task is to discuss the reports, then always ask her whether she knows the reports and always confirm the name and NHS number. The same risk factors, mental health support, and domestic violence, if relevant, all this becomes very important in an antenatal care history taking. And again, so the next, the routine histories, allergy, smoking, alcohol, drugs, and BBB. Examination, if required, if they have already given the scan reports or anything, then examination is not relevant here. If required, if nothing has been done, we can go for scans, blood tests. And the next one, it is the maternal medicine task. Here we should always start, if she comes with pregnancy, mostly if it is maternal medicine, she comes in early pregnancy for further care. She would not have taken any preconception counseling or anything. So in that cases, we should always ask with the pregnancy history first, pregnancy details, and then go to the disease history. But if the patient comes with preconceptional counseling, we should always appreciate her first. I appreciate you for taking, consultation before going on for counseling. So, and the next, we need to start with the disease history, and also it's important to take the history of whether she's taking any teratogenic drugs, because if she is planning for a pregnancy, we need to refer her to the concerned multidisciplinary team in order to change the drugs, or to change the drugs once she's pregnant, or whether we need to give a gap between the pregnancy and the planning. And also contraception history becomes important here in preconception counseling. And next, the related to the disease, ask her about the symptoms, when it was diagnosed, the course, and then medications, any hospitalizations, last specialist visit, and if it is in remission, since when it is under remission. For example, if it comes to asthma or any inflammatory bowel disease, then 6 months of remission is important. In that way, each disease has different kinds of necessities which needs to be fulfilled before going on to a pregnancy. And if always ask for any symptoms in the beginning when it comes to related disease history. That is, if it is asthma, does she have any breathlessness? If it is inflammatory bowel disease, then how is any vomiting, any abdominal pain, all that. After that, you can just ask 1 or 2 questions. That is enough to make sure that you're asking the symptoms. And so the routine history, again, MSF, support, mental health, domestic violence, if it is relevant, and all the other routine histories. Yeah. So the next one is the labor. So most of the time, the patient in such a task, the patient would be in labor, and we will have to either counsel her to go for a assisted vaginal delivery or going for a cesarean section. Sometimes the patient would not be would be adamant, I would not take it up. Then we'll have to discuss with her sensitively in a non-judgmental manner. So labor, there is only a few histories important that needs to be taken. So first of all, confirm the identity. Here again, am I speaking to? Don't start like, oh, I'm may I confirm your name? And first ask her about her birthing partner, and ask her how her pain is, if she's having any pain, whether she needs any painkillers. Then again, go into a short history of labor, when it has been started, and pregnancy history, risk factors, allergies, BMI, blood group reservations. These are enough. Don't go into the drugs history, smoking, alcohol. All that is not needed in labor. And examination to know at present how is her labor status, and CTG findings. Next is labor ward prioritization would be the next station that comes under the delivery module. So here in each task, that is each room, you need to take info related to what are the points to the labor. So these are the important points that needs to be there before you give your recommendation. So this comes under your background and assessment. So whatever background is already there, let it be there. Then ask about the assessment. If they've given the vitals and CVS, okay, so abdomen is there. Then ask if paler is necessary. Then ask about paler. That is if it is a uterine dehiscence, then paler all will be important. Then ask if the PV is not given, the PV. If any one of them is not there, then ask about that specifically. And it's also important to know about the mother's preferences. If it's going for assisted delivery, according to mother's preference, and after taking consent, we go for whichever kind of delivery. And next is the postnatal care. So postnatal care, again, always start with recovery. How are you? How is your recovery? And there are 5 Bs, that is baby, breastfeeding, bleeding, bowel, bladder, all this has to be taken. And then we also need to take the next history, which is the pain also is necessary, which has been missed here. Then again, mental health. How are you coping as a new mom? These are all standard questions that needs to be taken in a postnatal care task. Then again, whatever symptoms she's come with, explore the symptoms, any red flags according to the symptoms. If it's bleeding, then rule out anemia. If it's a pulmonary embolism, then rule out breathlessness. Such history has to be taken. And again, support is important in a postnatal care. And next is early pregnancy care. Most of the times, early pregnancy care, it would be a breaking bad news kind of a station. And so according to that, it should be a sensitive history taking. And always ask for UPT and if scan has been done or not. If the scan has not been done, then it has to be done, and we need to rule out ectopic according to the task history that has been given, what the patient is telling you. Then mostly, so it would be an anxious patient, so it should be an empathetic, sensitive history. And once the patient, she is sad and anxious, then we need to reassure her that we are there to take care of you. Next is support, then rule of domestic violence. If there is any bleeding, that is like a kind of abortion history, we can always ask. Domestic violence. Then again, all the blood group becomes important. BMI for post-op, what is that? Thromboembolism, prophylaxis, and then allergies, MSF. And we're coming to the last 5 tasks. Now we'll be starting with the gynecological history. So in the gynecological history, so I've already discussed about all the symptoms. According to the symptoms, anemia, rule out anemia, dizziness, breathlessness. Then here again, according to the symptoms, if it is bleeding or pain, always ask about her quality of life and mental health. This will give you, if you ask in the beginning itself, that will give you a lot of marks. Next is blood group reservations. LMP becomes important here. STI, smear history, contraception is very important when it comes to part 3 examination. And also it should be asked only if it is relevant. And menopausal history. If she's in menopause, ask about HRT, herbals, or any over-the-counter medications. Then allergies, domestic violence. If it is postcoital bleeding, this is a very important patient safety point. And BMI and smoking if it is relevant. Next, we come to the subfertility station. Here, routine history, that is years of subfertility, and if the partner, and what is important here is the partner is not available, do not disclose the partner details without the partner consent. If somewhere it says that partner has given consent, then you can discuss about both the reports. Then always ask the history related to both the partner and the patient. And infections, contraception becomes important. Then support and mental health is very important because the patients would always be distressed when it is subfertility. Then so for both the patients, ask for medical, surgical, family, allergies, drugs, smoking, alcohol, drugs, and BMI. And examination, it mostly will not be required because they'll be giving the reports. And if you're discussing reports, assess the prior knowledge. And if it is abnormal, always offer support before you break the bad news. The next is oncology station. So here again, we need to ask about all the 5 Bs to rule out any other conditions, and red flags such as weight loss has to be asked. And if you suspect any metastasis, then you can ask about any backache or any breathlessness, any headache, all that you can be asked. Then go for the smear history, becomes very important in an oncology station. If it is reports, assess prior knowledge. Then again, family history is important here. To know if it runs in the families, and then quality of life and support. Support becomes important if the patient is living alone or the husband is sick, then we need to provide appropriate support, that is social services has to come into the picture. And BMI if it is an endometrial cancer, examination investigations if it is relevant. And next is urogynecology. This is a very different task, and we need to ask a lot of different kind of questions, and most of the times we'll not be having enough time to complete the task. So urine pulmonary complaints, or for frequency and nocturia, and if there is any leak, and if there's any rush to the toilet with complete emptying, dysuria, and pain. You have your own set of questions in the set of in your order to ask. Then if there's any prolapse and mass down below, any discharge, bowel constipation should be asked. And risk factors, if she gives any SUI kind of history, chronic cough, and weightlifting has to be asked, or smoking, BMI becomes important in both. Then if it is urgency incontinence or overactive bladder fluids is important. And always the patients would have had some previous treatments. Always ask about her previous treatments and how was the recovery, that is how was the how much of her symptoms have reduced after the treatment, and medical, surgical, and allergies and drugs if you're going for surgery. And the last station is the sexual and reproductive health station. Here, according to the history, we can ask whether there's any discharge, foul smelling, any history of STI, smear, LMP, last unprotected sexual intercourse, contraception. Risk factors becomes important when it comes to emergency contraception, BMI, epilepsy, drugs. And if postpartum for contraception, ask about obstetric history, the recovery, allergies, examination, and UPT if it is relevant. So important